Hello, this is Dr. Hausinger, and this is the PowerPoint presentation for Chapter 2 of the Babor book, Matters of Substance. So if you've taken 400, this is a little bit of a review. We're going to look at the complexities of substances, and the 400 class goes much more in depth about this in terms of the actual pharmacological classes. So when looking at substances, we have to look at a couple different things. One, the pharmaceutical properties of the substances, both if they are naturally occurring or if they're synthetic, or if they were naturally occurring and then synthesized. So for example, something like wine or beer is very different effect-wise than hard alcohol. The cocoa leaves from which cocaine is synthesized is very different if you chew that than if you snort a line of cocaine. Okay. We have to look at the routes of administration, which is how a subject is taken in. So again, a review from 400, and we talk about this in 401 as well. Are there cultural meanings and symbolism and rituals, and is the substance within a certain culture? Why are people using? We look at set and setting and intention. And then harms associated with misuse. So again, I want to say that use in and of itself is not necessarily negative or bad. The truth of the matter is that the majority of people in the world that use substances don't have a problem with them, but it's about 10% of the population that does. Of that amount, 80 to 90% of that is alcohol, with the rest of it being substances other than alcohol. So if somebody's using drugs, we don't automatically assume that it's necessarily a problem. When you are a drug and alcohol counselor, you will be seeing the people with the problems. But I think sometimes we might jump to, oh, you're using a drug and you automatically have a problem. In reality, it's a very small percent of the population. However, the consequences from drug use affect us all financially. It affects workplace, it affects health, it affects the safety of our roads, etc. Okay, so there are three important distinctions to look at. One, are we looking at natural substances versus synthetic substances? Because the potency and the addictive properties change. If something is natural, it's less potent and therefore less addictive. We want to look at the route of administration. The more rapid the delivery, the more increased harm we have, risk, and misuse potential. For example, assuming that we are taking our medication as prescribed and not doubling or tripling the dose or mixing it with something else, something like Tylenol, when taken orally, has very little risk unless you have a contraindication. However, if we take a bottle of Tylenol and mix it with alcohol, we could potentially lead ourselves to liver failure. Okay. The body is armed with amazing defense systems, and when we bypass those systems through intravenous use, we are exposing ourselves to risk because we go right into the bloodstream, and the body doesn't have the ability to metabolize things and break things down or filter as we do even with smoking or nasal ingestion, because we have all of the cilia on the inside of the nose, etc. Okay. And then third, is the substance accepted as medicine? And one of the most relevant topical topics right now is that of marijuana. It is becoming increasingly recognized as medicine, whereas previously it was not, and therefore the illegality contributed to the stigma behind it. So a couple things with this. We have off-label use, which means that the substance is being prescribed for something that it was not previously tested for with the FDA. Okay. So prescribing something that's not usually for the ailment that you have, it would be considered an off-label use. Okay. Increased dosage. Are we increasing the dosage? And dose is very important in general when looking at, is it a toxic dose? Is it a medically recognized dose, or is it a lower dose? Again, everything in moderation. So something as benign as taking a Tylenol, if we were to take a couple bottles of it, then becomes something that was not being used as medicine, and the intention shifts. And then in regards to, is it accepted as medicine, that goes into policy, politics, and law. What is the risk of physical, psychological, and legal problems? And a little bit later on, we're going to be talking about the DEA scheduling of drugs. Drugs are listed in classifications varying from, this is very harmful and there's no medical use, to, yeah, this is pretty safe and there's medical use. When we're looking at the word diversion for the purposes of this class and policy and law, diversion means that it was taken away from its intended use. So for example, maybe you have a physician at a hospital who is stealing pain pills because they are addicted. That would be diverting the substance from its use, from its primary purpose. You're stealing it from a hospital. It wasn't prescribed to you. Okay. So things that we need to consider are the specific roles of consumption patterns. And this is on a micro, meso, and macro level. So on the micro level, we would look at the individual drug user's use history, which is dimension 5 of ASAM. Then we would look at the meso, a community, and then global patterns such as importation, trafficking, etc. Okay. Situational and behavioral risks. Again, micro, meso, macro, the individual, the community, and then a macro level. And we're going to talk about the world drug trade a little bit later on in the course. And then what are the effects of the combinations of substances? And this comes down to pharmacology. Potentiation, cross categories of drugs. Are we mixing uppers and downers? Are we mixing two downers to get an even more depressed effect? Are we missing stimulants? Are we using all-arounders? Okay. Are they potentially lethal combinations? Okay. And then we want to look at diversity and cultural competency when looking at these things. Okay. Right. Routes of administration. We can think of this in terms of both licit and illicit substances. So generally, if you have a headache, you're probably not going to snort your ibuprofen. I would hope not. That would probably hurt. You would take it orally. Okay? Many times, addictions to pain medicine starts with oral consumption of a prescribed medication. Okay? We also ingest alcohol orally. Okay? Nasally. So these intranasally, here you go. These are the abbreviations that you would see in a clinical form because it's just too long to write this. So these are our abbreviations. One might take Afrin or a nasal spray. Okay. Similarly, somebody might snort cocaine or methamphetamine or heroin. Right. We don't see too much about smoked drugs in terms of legal drugs. Certainly people smoke cigarettes, and you can smoke pretty much any substance if you can put it into a form that you can burn it and inhale the fumes. Okay, so meth, heroin, cocaine, etc. Right. Now, backing up a minute, oral ingestion can take anywhere from 15 to 30 minutes to for the person to feel the effects. Nasal and smoked are pretty quickly 10 to 15, 5 to 7 or 10 seconds or so. So actually, a lot of people think that IV use is the fastest, but you actually feel the effects faster with smoking. This is about 10 to 15 or so, and then this is quicker. Inhaled insufflation, huffing, so that's a little bit different than nasal. This would be inhaled maybe through the mouth and nose. Okay, we might inhale essential oils to break up a cold. Then a lot of drugs are huffed or inhaled, like paint thinner, whiteout, etc. A topical example would be calamine lotion if you get poison ivy, okay, or your birth control patch or a fentanyl patch. Okay. LSD can be absorbed through the skin. Okay. So if you're around LSD and you don't want to take it, be very careful that it doesn't touch your skin. Intramuscular injection is a very slow-moving form of administration. It takes a while for it to get into the system. And so an example of this would be your flu shot or your birth control shot, usually right in the butt or right in the thigh. Your EpiPen is this as well. Drug-wise, when people have been using for a long period of time and their veins collapse, they might start to use in an intramuscular way. We're familiar with intravenous. It is very quickly and it bypasses the body's defense systems and go right into the bloodstream. So if you are chopping vegetables and you cut your thumb off, an ibuprofen orally isn't going to cut it for you. You're probably going to need IV drugs to stop the pain. So a lot of things can be taken intravenously, morphine, etc. And then, of course, we're familiar with illicit IV drug use, cocaine, heroin, methamphetamine. Okay. Subcutaneous injection, also known as skin popping, is most commonly found with the tuberculosis shot, where you would pop the skin up. You gather the skin with 2 fingers, and then you shove a needle into the little pocket that you created. Veterinary medicine uses this a lot if an animal needs fluids. And then, again, if somebody's veins have collapsed, they might try to inject wherever they can. Anal absorption, a suppository, an enema. Okay, sometimes people do colonics or absorb minerals and nutrients that way. We do hear stories of people that might have had throat cancer in part due to smoking and alcohol, and then they try to take alcohol anally. This is a good way to overdose and to die because you have all the exposed blood vessels, and the membranes and cellular walls are very thin in that area. It's a very sensitive area. Same thing with vaginal absorption. Somebody might use a spermicide or a yeast infection cream illicitly, and then again we might hear stories of people dipping tampons into alcohol and inserting them up there, and that can cause toxic shock. Okay, so all of the routes of administration have their time and place, both licitly and illicitly. When we're looking at drug histories, we can see somebody's tolerance and progression of their addiction when we look at the progression of how they are administering the drug. It does happen that people start using needles right away, but that's more of the exception than the rule. Usually there is a progression. If somebody is using needles, somebody might have forced them to do it. It might have been pressured. They might have been bribed. Sometimes people are forced needles and then they're sexually assaulted. So in general, though, we're looking at a progression. Very common with opiates. People start taking them orally, and then they start crushing them and snorting them, and then they smoke them, and then potentially going to intravenous use. Okay. So looking at the symbolic meanings and use patterns behind different substances, some substances have medicinal and religious rituals connected to them. For example, tobacco use could be a regular accompaniment to everyday life. Many people start their day with a cigarette and a cup of coffee, and that becomes a ritual, something that you do every day. The book discusses that marijuana at a time was a symbol of rebellion, and we see different substances portrayed in music and media as symbols of cultures. Okay. Right. Now, use can potentially lead to addiction as well. We have the secular and non-medicinal use patterns and attitudes shift over time, and we're in the middle of the shift right now in regards to the American perception of marijuana. And as of 2016, around election time, about 61 to 70% of Americans were pro full federal legalization. So when we look at shifts over time, we have to look at power and domination. Who is in control? What is the political climate? Example, are there drug kingpins looking at symbols? A good example of when you're looking at that is Freeway Ricky Ross, a very powerful symbol in the 80s. We're looking at social behavior used with symbolism. So, for example, club drugs, different cliques, different communities are more likely to use certain drugs than others. In the 400 class, we look at the relationship between music and certain types of drugs. So if I say rave or rave kids, right there, certain images and music and clothing or lack thereof, images are going to come up, as well as the association with things like ecstasy. Okay. And drugs have the power to change behavior, mood, motor coordination, and judgment, and that's your basic pharmacology, and that has negative and positive connotation. Page 17, these expectations and people's behaviors while under the influence of the substance vary among cultures. So, for example, hallucinogens being used by a medicine man or medicine woman to help somebody deal with a trauma in their culture would be perhaps differently perceived than somebody taking mushrooms and playing Mario Kart during the weekend, as an example. Okay. Cultural attitudes. So I'd like you to think about other examples that come to mind in terms of drugs, cultures, and how we perceive them. You might think about Rastafarianism. You might think about the grunge music scene in that culture. You might think about field workers in Afghanistan, etc. So why do people use drugs? Why do people use substances? People have been using substances since substances have been discovered. And they act upon the motivation, thinking, mood, and pleasure. So again, we want to look at set and setting. Why is the person using the substance? What is it adding to their life? Is it something positive? Is it something negative? Pleasure is rooted in biology. We look at the pleasure center in the brain, and then it is reinforced socially as well. Okay, so for example, if I struggle with anxiety and I have a couple drinks and I feel better, and then I can go out and hang out with my friends and be an awesome life of a party, that's something that I receive, biological pleasure, and then it's reinforced socially. Cultures learn a symbolic value. Okay, again, thinking about music, thinking about the summer of love and substances being consumed in public as protests to the Vietnam War, etc. Availability and attractiveness of the drug, and later on we're going to look at what causes supply and demand and what happened, what makes some drugs more attractive than others. Okay. And in genetic predisposition in the 400 class, we look at this in chapter 3 largely about heredity, and most experts, the studies vary between 40 to 60% is genetic and plays a hereditary predisposition. We've been able to look at that through twin studies. Okay, and then the rest of that can be a lot of different things. Is it nature? Is it nurture? So nature, of course, being genetics, nurture being environment. Okay. Chronic use and dependence are part of a complex biobehavioral syndrome that differs according to the nature of the substance and the user's personal characteristics. So substances affect people in different ways. For example, a person that has ADD or ADHD, stimulants might calm them down. In fact, stimulants like Adderall and Ritalin are amphetamine based. If a person that does not have ADHD or ADD were to take an Adderall or a Ritalin, they'd be speeding all over the place. Okay. Mechanisms of harm. So we want to look at what is the nature of the substance and the pattern of use, amount, and frequency. Okay, because we can look at withdrawals and tolerance in terms of seeing if there is a problem. Set and setting, what is the experience? Okay, and is the set and setting, is it becoming increasingly risky or not? Right. Are there toxic and biomedical effects of the drug? So going back and looking at dosage, which is really important when we're looking at pattern and use, right? So having 1 to 2 glasses of red wine every night as prescribed by your heart doctor is a very different intention than drinking 2 bottles of wine every night because of anxiety or depression, etc. Okay. Psychoactive reactions resulting in intoxication. We want to look at, this is important, are they using to the point of intoxication? A person can drink alcohol every day, and they could actually have several drinks throughout the day without becoming intoxicated at all. Okay. Right. And then on page 20, they have a nice chart here looking at dependence, and this word is not used ubiquitously, meaning all over the place. In fact, we're looking at it more in terms of the DSM. Dependence means physical dependence as indicated by withdrawal and tolerance. Okay, so there's a great chart on page 20 that you can look at. How toxic effects, intoxication, and dependence are related to drug dose, use patterns, and mode of drug administration, and in turn mediate the consequences of drug use for the individual drug user. So here you have, at the very bottom of the chart, you have a lot of different effects. Effects on the fetus, overdose, injury, infectious disease, chronic illness, role failures, and criminal punishment and stigma. And then further up on the chart, you have social reactions to use, dependence, intoxication, toxic effects, context of use, and then you have the psychoactive dose, the pattern volume of drug use, and the mode of administration. So all of those things go into informing the severity of the problem, if there is a problem. Okay. All substances are not equal. All substances are not equal. In the 12-step programs, they will often say a drug is a drug is a drug. And what they mean by that is that a person can switch substances, they can switch addictions, and potentially have similar consequences. What we're looking at with a capture ratio, we mean that some substances have higher addicted rates than others. Okay. So looking at figure 2.2 and the margin of exposure. Okay. This is how we measure potential harmfulness. And a capture ratio is the proportion of users who develop dependence on that substance. Heroin and methamphetamine are considered to have the highest dependence potential, followed by cocaine, pentobarbital, nicotine, and alcohol. And this is at a global context. Okay. We want to look at toxicity in terms of lethality. And we want to look at the social dangerousness. Social dangerousness, which is on page 25. So, in general, for example, heroin and alcohol rank relatively high on all 4 dimensions of dangerousness, with cannabis scoring in the lowest range. And there's a figure here. 2.3 psychoactive substances ranked by their overall harm scores. So if you were to look at this chart, alcohol is by far the highest in overall harm. And then we have magic mushrooms and buprenorphine down at the bottom. Okay, so please look at that. And then we're going to look at the hypocrisy of DEA drug scheduling. We have this research and we know it to be true. However, if you look at the American DEA drug scheduling, it is very much in contrast to these global charts. Okay, so a lot of interesting things to look at. Please look at things with scrutiny. We're going to talk a little bit more about the global perspective in Chapter 3.